Welcome to KJR SummaryCast, audio summaries of peer-reviewed articles published in the Korean Journal of Radiology. Designed to enhance reader convenience and the overall KJR experience, SummaryCast provides conversational audio overviews for time-constrained listeners and mobile-friendly learning. This recording was created using a combination of AI tools with oversight from the KJR editorial team or the article's authors, including necessary edits and corrections. For the most accurate and complete information, we encourage you to also read the original published article.
Welcome back to SummaryCast. Today we are unpacking a topic that is absolutely exploding right now, not just in the media, but in the reading room.
Oh, it's everywhere. We're talking about the collision of advanced imaging and the new wave of anti-obesity drugs.
Exactly. We're looking at a review article titled Potential Role of Imaging in the Evaluation of Adiposity and Approval of Anti-Obesity Drugs. This was published in the Korean Journal of Radiology, appearing in the early 2026 issue.
It's a fascinating read because it really connects the dots between these blockbuster drugs like Wegovy and Zepbound and the imaging biomarkers that prove they actually work.
Right, because for the longest time, the metric for success was just the scale.
The bathroom scale, or BMI.
Which, let's be honest, is a pretty blunt instrument.
Blunt is a polite way to put it. BMI tells you nothing about body composition. You can have a linebacker with a BMI of 30 who is pure muscle, and a patient with sarcopenic obesity who has a normal BMI but dangerously high visceral fat.
And that distinction is exactly where this paper starts. The authors argue that as rates climb, nearly 60% of the world's population may become overweight or obese by 2030. We need tools that actually look inside.
We need to see the fat, not just how much there is, but where it is.
So let's set the stage with the regulatory landscape. This is one of the most interesting parts of the paper. They discuss a major shift from the FDA.
Yes, the January 2025 update to the FDA guidance on obesity drug development. This is a big deal.
What changed?
Previously, weight loss was king, but the new guidance explicitly emphasizes that the goal is long-term fat mass reduction, not just weight reduction.
So they want to make sure patients aren't just losing muscle.
Precisely. They want to see preservation of lean mass. And the FDA, along with the Korean Ministry of Food and Drug Safety, is now encouraging imaging data in clinical trials to prove this.
Which puts radiology front and center. So let's walk through the toolbox. The paper breaks down the four main modalities: DXA, CT, MRI, and BIA.
Let's start with the workhorse, dual energy X-ray absorptiometry, or DXA.
It's the standard, right?
It is. It's widely accessible, relatively cheap, and the radiation dose is tiny. We're talking 1 to 10 microsieverts.
That's less than a chest X-ray, comparable to daily background radiation.
Exactly. So you can use it repeatedly for monitoring. The mechanism is elegant. It uses two X-ray beams at different energy levels.
Usually 40 to 47 keV and 70 to 80 keV.
Right. Bone attenuates them both strongly. Soft tissue attenuates them differently depending on whether it's fat or lean mass. So DXA can give you this three-compartment model: bone, fat, lean.
But it's not perfect. It's a 2D projection.
That's the catch. It struggles with visceral fat specifically. It has to estimate visceral fat based on the android region.
Define that for us.
It's a region of interest typically defined between the last thoracic rib and the iliac crest. The software takes the total fat in that box, subtracts an estimate of subcutaneous fat, and assumes the rest is visceral.
So it's an indirect measure.
It is, but its studies show it correlates well with CT and MRI. However, it can be thrown off by hydration status or even what the patient had for lunch.
Right. Bowel contents count as lean mass in some algorithms, don't they?
They can. And in patients with extreme obesity or extreme cachexia, the accuracy drops.
Okay, so DXA is the screening tool. But if we want precision, especially for that dangerous visceral fat, we move to cross-sectional imaging. Let's talk CT.
Now we're talking gold standard territory, at least for segmentation. The paper emphasizes using attenuation-based thresholding for tissue separation.
And the paper gives some specific ranges.
Yes, skeletal muscle usually sits between 30 and 100 HU. Adipose tissue is much lower, typically -30 to -190 HU.
So you can threshold that perfectly.
You can, and unlike DXA, CT can distinguish visceral fat from subcutaneous fat with anatomical precision. You can see the fat wrapping around the organs.
But there's a nuance here that the authors highlight. It's not just about the fat around the organs, it's about the fat inside the muscle.
Myosteatosis.
Right. This is a critical concept.
Huge. It's when you have fat infiltration into the skeletal muscle. On CT, this shows up as low attenuation muscle. The muscle looks less dense because of the microscopic fat.
And myosteatosis correlates with poor outcomes. Decreased muscle function, metabolic syndrome, even higher mortality in cancer patients.
Exactly. It's a quality measure, not just a quantity measure. DEXA can't see that. DEXA sees lean mass, but it doesn't know if that lean mass is healthy muscle or marbleized with fat.
But the downside of CT is obvious: radiation.
Always. You can't justify serial abdominal CTs just to check a waistline. A standard abdomen CT is 5 to 10 millisieverts.
That's 1,000 times the dose of a DXA.
Roughly, yes. But the paper points out that for research, they use single-slice protocols or low-dose protocols that drop that exposure down to about 15 to 19 microsieverts.
Which is manageable. But clinically, are we really going to order CTs for obesity monitoring?
Maybe not specifically ordered for that, but this brings up the concept of opportunistic imaging.
I love this concept. Use the scan you already have.
Exactly. Radiologists are looking at thousands of abdominal CTs for other reasons: pain, oncology staging, trauma. That data is sitting there.
We just need to extract the body comp data from it.
And that's where AI comes in, which we'll touch on later, but first we have to mention MRI.
The other gold standard.
The radiation-free gold standard. MRI offers the best soft tissue contrast, and the techniques have gotten very sophisticated.
They highlight the Dixon method.
Classic chemical shift imaging. It exploits the difference in resonance frequency between fat protons and water protons. You get a water-only image and a fat-only image.
Clean separation.
Very clean. And then you have PDFF, proton density fat fraction. This is a quantitative map where every voxel has a value from 0 to 100% fat.
This is crucial for things like MASLD, metabolic dysfunction-associated steatotic liver disease, formerly NAFLD.
Correct. MRI is the only non-invasive way to quantify liver fat with that level of precision. It can detect trace amounts, less than 5%.
But it's expensive and slow.
It is, though the authors mention abbreviated protocols that can cut scan time significantly. Still, you're fighting for magnet time.
So we have the tools. How are they actually being used in these blockbuster drug trials? The paper does a deep dive into the recent approvals.
Let's look at semaglutide first, Wegovy, the STEP trials.
Specifically, Step 1.
Right. This was a massive trial, but they had a sub-study of about 140 participants who underwent DXA.
And what did the imaging show?
After 68 weeks, the drug group lost 3.48% of total fat mass compared to practically zero in the placebo group.
But more importantly, what happened to the lean mass?
The proportion of lean body mass increased by about 3%. Now, to be clear, they lost some absolute amount of lean mass. You almost always do when you lose weight. But the ratio shifted favorably. They lost more fat than muscle.
And they went further in Step 6.
Step 6 was interesting because it focused on East Asian populations and used CT. They measured visceral fat area at the umbilical level.
And the results there were pretty dramatic.
A 40% reduction in visceral adipose tissue.
40%?
Yes, 40%, compared to roughly 7% in the placebo group. That is a massive physiological change.
That's effectively remodeling the visceral cavity.
It is, and that ties directly to the reduction in cardiovascular risk we see with these drugs.
Then came tirzepatide, Zepbound, the SURMOUNT trial.
This is the dual agonist, GLP-1 and GIP. They also did a DXA substudy. The reduction in total fat mass was nearly 34%.
That is huge.
It's staggering. And look at the fat to lean mass ratio. It dropped from 0.93 to 0.7.
So the imaging proved that the quality of the weight loss was high. It wasn't just dehydration or muscle wasting.
Exactly. And that data was key for the regulatory narrative. It moves the conversation from cosmetic weight loss to metabolic health improvement.
But, and there's always a but, using imaging in the real world isn't as clean as a clinical trial.
No. The paper points out some significant hurdles.
Standardization seems to be the big one.
It's a mess. Take visceral fat area, VFA. What's the cutoff for abnormal?
The Japanese Society for the Study of Obesity says 100 square centimeters.
Right, but a Korean study of over 30,000 people suggested 134 for men and 91 for women. We don't have a global consensus.
And that varies by height, age, ethnicity.
Exactly. If you're writing a radiology report, you can't just say increased visceral fat. We need numbers, and we need reference ranges.
And then there's the issue of where you measure. Umbilicus, L3, L4, L5.
The paper notes that standardizing anatomical landmarks is critical if we're going to compare data across institutions or even across time for the same patient.
This brings us back to AI, because asking a radiologist to manually segment visceral fat on every abdominal CT is...
It's a non-starter. Nobody has time for that. It is labor-intensive and time-consuming to do a manual segmentation properly.
So AI is the only way this scales.
It has to be. The authors discuss deep learning models that can segment subcutaneous fat, visceral fat, and muscle with dice similarity coefficients over 0.9.
Which basically means they are as good as a human expert.
Pretty much, and they can do it in seconds. This unlocks that opportunistic imaging potential we talked about.
Imagine a workflow. A patient gets a CT for kidney stones. The AI runs in the background. The report comes back with the stones, but also says, visceral fat area 150 centimeters squared. Skeletal muscle density indicates myosteatosis.
That turns a diagnostic scan into a preventative health screen. It adds immense value without extra radiation or extra scanner time.
But we're not quite there yet.
We're close. The algorithms exist. The challenge is integration into the PACS workflow, and again, agreeing on what to do with that information.
Right. If a radiologist reports it, who manages it? Is the urologist ordering the stone study going to prescribe Wegovy?
That's the clinical gap, but radiology provides the data.
The paper also touches briefly on BIA, bioelectrical impedance analysis.
Yeah, the scales you stand on that send a small current through you.
They're cheap, portable.
They are, and good for field studies, but the error margin is higher. It assumes a lot about hydration and body geometry.
So not for rigorous clinical trials.
Not for the primary endpoint, no. But fine for tracking trends at home, maybe.
Let's loop back to the cost effectiveness. The paper argues that even though CT and MRI are expensive, this opportunistic approach might change the math.
It flips the math. If the scan is already paid for, the marginal cost of the body comp analysis is near zero, assuming the AI software is affordable.
And considering the cost of obesity, diabetes, cardiovascular disease, joint replacements, catching high-risk body comp early is valuable.
Extremely. And with these new drugs being quite expensive, payers might eventually want objective proof of efficacy. Not just did you lose pounds, but did you lose fat?
That's a really interesting point. Imaging as a gatekeeper for continued therapy.
It's possible. If a patient is losing weight but it's all muscle mass, you might want to stop the drug or change the dose. You'd only know that with DXA or CT.
So, bottom line, the authors conclude that while DXA is the current king for cost and access, the future is likely a mix.
A mix where CT and MRI provide the deep phenotyping, telling us about liver fat, myosteatosis, and precise visceral fat, while DXA handles the population-level screening.
And AI acts as the bridge to make the cross-sectional data actually usable.
Precisely. It's moving radiology from just looking at pictures to providing quantitative biomarkers for metabolic health.
Which is a huge opportunity for the field.
It's an entirely new service line, potentially.
It puts the radiologist in the middle of the obesity epidemic management team.
Right where the specialty needs to be.
So, if you're reading abdominal cases today, maybe take a second look at that psoas muscle on your next scan. There's a lot of information hiding in those pixels.
More than meets the eye.
Thanks for listening to SummaryCast. We'll catch you on the next deep dive.
See you then.